Welcome back. I hope everyone is ready for another insightful session on infectious diseases. Let's extend a warm welcome to our session chair, Dr. Manzoor Ahmed, consultant pediatrician neonatologist, adjunct clinical assistant professor, University of Sharjah, University Hospital Sharjah, UAE. Welcome, Dr. Manzoor. The session is yours.
Assalamu alaikum. Good afternoon, everybody. Welcome to our second session of the day today. Before I would begin the session, I would like to take this opportunity to thank Dr. Junaid Khan and Dr. Ayman Rahmani, the organizing and scientific chairman of this conference, for inviting me here, and also congratulate them for having a highly scientific and acclaimed conference. Now, the first speaker for today's session is Dr. Hafiz Ponambat, who is a consultant neonatologist at Cornish Hospital, Abu Dhabi. He is going to talk a very interesting topic about neonatal implications of emerging or re-emerging infectious disease in neonates. Please welcome Dr. Hafiz. Thank you.
Thank you, Dr. Mansoor. And first of all, thanks to Dr. Ayman, Dr. Junaid, and the organizing committee of the conference for inviting me to this talk. Do I just touch here? Is it touch screen? Okay. Right, okay. So I'm going to talk about something which is not usually spoken about at our neonatal conferences, the implications of emerging and re-emerging infectious diseases. The reason I chose this topic is we are in a region where there's a huge flux of people from all over the world, and we are constantly kind of threatened by these infections. And my interest in this was piqued as a member of the SAHA Infectious Disease and Infection Control Committee, where all these guidelines come for review, and there's very little mention of what happens to babies if they're born to mothers who have these diseases. There is some mention there, so I decided to look at what's going on out there. So when you talk about emerging infectious diseases, it can be an infection which has newly appeared, like we saw in the last 5 years, and we were battered by it, COVID-19, never seen before, and it suddenly came on and devastated the world. Or these have been diseases which have previously existed in small pockets in some corners of the world and starts emerging in new areas or rapidly expanding in an area. And these emerging infectious diseases have been around as old as mankind. So they are mentioned in all the religious scripts where they were thought to be punishments from heavens above, like the biblical plagues. Then there was smallpox, which devastated vast populations, the Spanish flu, which killed millions at the beginning of last century. So they've been around for a while. And also when people invaded untouched territories like the Caribbeans, where the Europeans went and invaded, they brought new diseases and wiped out entire indigenous populations. So these diseases have been around for a while, and they're just coming out with new flavors. Now, when these diseases were emerging, then germs were discovered in the last couple of centuries, and antibiotics were discovered, and there was a lot of optimism, and people predicted impending victory against infectious diseases. And not too long ago, maybe 50 years ago, the US Surgeon General said the war against infectious disease has been won. Joke of the century. He might be somebody who our current president in the US might like to employ for such good news, but far from the truth. Now, for classification of emerging infectious diseases, they can be newly emerging, like I said, about COVID-19, which was never heard of before, or re-emerging. These are diseases which had caused problems in the past, went away, and we are seeing them again. And the small group called deliberately emerging, these are bugs with potential for bioterrorism, which some people claim COVID-19 was, but who knows. So there are potentials for lots of emerging diseases and classifications. And this is just a timeline showing the various bugs which have made an appearance in the last 2 decades even. The lots of viruses which were known about in small pockets of different parts of the continent appearing in other parts where it was never expected to be, in Europe, US, South America, and to our shores as well. Now, why is this happening? So microbes adapt and change. So bugs which existed only in animals suddenly mutate and find new hosts. or new vectors emerge and they come to the human population. The increasing susceptibility of human infection, probably because of changes in vaccination policies, changes in the genome even, and the microbiota. Climate and weather, which is rapidly changing around the world. Dry areas becoming wet areas becoming dry, which changes the ecosystem, the vectors, and the changing in ecosystems. For example, the hantavirus outbreaks in the US, where rodents were the primary kind of vectors, and when they ran out of food, they moved into urban areas, and not too long ago, an actor and a wife in the US died of hantavirus because of rodent urine. Human demographics and behavior, how that changes, rapid urbanization and land use. Our area is a pretty prime example of that. Dubai, which had a couple of streets 50 years ago, is a sprawling metropolis with big bodies of water which are stagnant. All that changes how vectors breed. International travel, and that's so relevant in this part of the world where we have two large airports, people passing through all the time, and nationalities. On the last count, there were at least 180 different nationalities living and working here. Technology industry, and in other parts of the world, breakdown of public health measures, poverty and inequality, war and famine, which leads to kind of destruction of resources, what's happening in Gaza now, and people moving, refugees moving into new environments, and all the problems they bring with. And there's a lack of political will. You might have the resources, but there's no political will. And finally, the intent to harm, bioterrorism. All these can cause emerging infections. And the GCC region and UAE especially fits most of the criteria on the left side of the screen because of the nature of the life and business here. Now, just touching upon what are the likely bugs we are going to see in the next few years. So we live in the GCC and the wider MENA region. So if you classify into what sort of bugs we are likely to see, bacterial priority pathogens as kind of classified by WHO, there are MDROs emerging. So these are bugs which were considered benign in the past, but now they become resistant to most antibiotics you know of, and they are spreading. Then we have the viral vector-borne diseases, like, for example, chikungunya. It's not on the shores of UAE yet, but it's around us, and it's only time that we might see one in UAE. Similarly, all the flaviviruses, the dengue, West Nile, yellow fever, they are in countries very close to our shores. And with people traveling back and forth and vectors proliferating in the UAE, you might start seeing them here soon. Then there are the viral zoonoses, for example, the Crimean Congo hemorrhagic fever, the MERS-CoV, rabies. Till now, we are a rabies-free country, but vigilance has to be kept up. And now the other worry, the vaccine-preventable diseases making a resurgence, like pertussis and measles, which I'll touch upon later. And of course, parasitic infections, which living in affluent areas like ours, with which we thought there were no vectors, we had forgotten about, but they're making a reappearance even in our communities. So now what are the neonatal implications for this? Of course, the first thing is about risk of vertical transmission and what we might see when these babies are born. And they can acquire it postnatally as well if the mothers or close family members are infected. Some of them leading to congenital malformations, which we'll touch upon. And we don't know the long-term consequences of some of these diseases when they affect newborns in the early stage of their life. So of course, in half an hour, I'm not going to be able to touch of all the bugs I've talked about. I've picked out a few which we might end up seeing here soon or are already seeing in the high-risk group, and the others which are listed there, I won't be discussing much about. Coronaviruses, you've heard at length over the last 5 years. I'm not going to bore you with it anymore. All of us know how coronavirus has affected the mothers and babies and how we managed. So let's start with neonatal dengue. So when I moved to the UK and then moved, I had forgotten about dengue because in India it was so common. But then things have changed. So let's talk a little bit about dengue. It's caused by a virus in the Flaviviridae group, 4 strains. I'm not going to elaborate on that. And it's transmitted from human to human by the Aedes aegypti mosquito. When I came here 10 years ago, I was so glad there were no mosquitoes here, but that has all changed in the last few years. So after the floods of last year, there has been a big problem with dengue in and around UAE. In Abu Dhabi alone, the last year, there were more than 2,000 cases reported, and more across UAE. So it is here. We haven't at least seen any reports of neonatal dengue, but the problem is it's not easy to pick out unless you suspect it. So neonatal dengue can happen from maternal fetal transmission if the mother has been infected in the last few days of pregnancy. It can happen by mosquito bites and rarely with contaminated blood. So what happens during pregnancy? So if a mother gets dengue, it's very often it can mimic something like HELLP syndrome. So they might have hemorrhage, they can have slightly high blood pressure, low platelets, and they might be classified as HELLP syndrome. This is common with most of the hemorrhagic viral fevers in pregnancy. Unless you suspect it, you don't pick it up. But the history might give us a clue. And with like every other viral illness in pregnancy, the mortality is higher in mothers, which indirectly affects the fetus and the baby. And for babies, it has been shown in places like India where it's very common if mothers are affected with dengue during pregnancy, they can have risk of oligohydramnios, preterm and intrauterine fetal death in the early stages of pregnancy. So the highest risk for a baby to acquire dengue is if the mother catches the infection the last 10 days of pregnancy where the viremia is maximum, and if the mother is febrile. So when would you suspect dengue in a baby? It depends on the maternal history and if it's a mosquito season. So Aedes it's a mosquito which bites during the day, and if there's lots of mosquitoes around, that might be the reason. Or if a mother's recently traveled in from an endemic zone, you need to kind of suspect this. And it might be indistinguishable from sepsis. They may have fever, thrombocytopenia, leukopenia, all the things which you associate with neonatal bacterial sepsis. But the clue might be there are no inflammatory markers and you're kind of struggling to explain what's going on. And that's where the history becomes important, which I keep drilling into my trainees. It's a lost art, taking history. History becomes vital in these situations. The good thing about dengue in newborns, it's milder than in older children and adults. This is because they say there's an immunological component to the dengue shock syndrome, dengue hemorrhagic fever, because of exposure to the viruses in the past. Most of the reported cases from India and the wider subcontinent, they have survived. Very few deaths. But we need, and there's no specific treatment. The management is mainly supportive. If you have low platelets, you correct that. If you have shock, you treat that. Of course, you would use antibiotics because we don't know any better. So it's all symptomatic. And the diagnosis is the usual virology techniques. Then in the last few years, we kept hearing about monkeypox, and we were wondering how does that affect us? How does it relate to pregnancy and the newborns? So monkeypox comes from the same family as the smallpox viruses. It's an orthopox virus. It first described in monkeys in 1958, and first human case was described in 1970. So this is an example of a virus changing its nature. It was a zoonosis first, which has jumped into human beings. So there are two types. They call it clade 1 and clade 2. The clade 1 was largely limited to Central Africa, and clade 2, the West African clade, and that's supposed to cause the most severe disease. And in the last decade, there's a spread around the world because of travel. And also people think this is now spreading more because if you remember our parents, they were all immunized for smallpox growing up till it was eradicated in the 70s. And that herd immunity to smallpox has waned off because there's cross protection. And so monkeypox is finding it easier to infect humans. So in 2022, there was a rapid proliferation of this bug around the world, and WHO had declared it as a public health emergency of international concern. But thankfully, it has waned off, but we just need to maintain vigilance. So human-to-human transmission is through close physical contact, and including sexual transmission has been described. And the case fatality ratio, though it's a mild illness majority of the time, the reported fatality ratio is around 3 to 5%. So in pregnancy, the symptoms are very similar to what you will find in the general population. They have a viral prodrome, they have the typical rash, and unless you suspect it, you won't recognize it. So newborns, they can get it through vertical transmission. It might be vertical. If there's rupture of membranes, it can be hematogenous or direct placental infection. And in pregnancy, it can lead to preterm birth, and if infected early on in the first trimester, the miscarriage rate is quite high. It can present as high drops, IUGR, and maternal mortality. Now, neonatal mpox, when I kind of search the literature, say, what do we do with these infants? We find them. There are not that many reported, but there are. Mostly reported from Congo, which usually they haven't reported any live-born babies, but late stillbirths with a typical rash. The one case I could pick out, which was reported in literature, was from London in a child admitted to Great Ormond Street PICU with severe respiratory failure requiring ECMO. And when my friend who works there took the history, the father had a rash a week after the baby was born. And then while the baby was on PICU, he also broke out in this rash. So babies can become pretty sick with this. So it's like a vesicular rash which can erupt all over the body. So you need to maintain a high index of suspicion. So if you have an unusual rash, go into the history. So the diagnosis is, of course, the history, the clinical features, and PCR from the fluid or fluid from the lesions. The treatment mostly supportive, but there are medications which have been recommended by WHO in adults. In newborns, it is still experimental. It's two drugs. It's called tecovirimat and cidofovir, which can be used. I'm not going into the details of dosage and everything. If we find something like this, of course, I'll be approaching my ID physicians for advice. So it is treatable, but you need to suspect it to treat it. The next disease I want to talk about, because this has reached our shows, there have been reports of this disease on our shows. We haven't seen any pregnant women yet, or at least reported. We haven't seen any at our hospital. Is Crimean Congo hemorrhagic fever. The origin of this virus is in the name. So it was first noticed in Crimea, which has now been annexed by Russia, which is a part of Ukraine. And then it established itself in Congo. And this were the pockets where it was mostly seen. But because of population movement and because of international travel, it has moved to other areas. So it's a zoonotic illness, which is usually caused by RNA virus belonging to Bunniaviridae family. And it's endemic in Africa, parts of the Middle East. It's not endemic here yet. Here we get sporadic cases. In Eastern Europe, the largest number of cases are reported from Turkey, the European bit of Turkey. And it's transmitted by ticks. But in our environment, it's because we don't have that many ticks here, it's mostly through blood and body fluids of either infected animals, which are slaughtered, or humans who have been affected by it. And in hospitals, there's a potential of nosocomial spread. It's a highly infectious disease. And if you get a patient with CCHF, they have to be put under strict isolation with airborne and contact precautions. And the mortality rate is quite high, 10 to 40%, and even higher in pregnant women. So this is not a disease we want to see, but if seen, we need to deal with it. So this is how the disease progresses. They go from, like every other illness, incubation to a pre-hemorrhagic phase, and once they hit the hemorrhagic phase, the mortality rate is quite high. Quite often, you might not even realize that you have it, like a lot of the viral infections. And the bit is, like long COVID, there's a long CCHF. So patients who have recovered from it have a long, difficult period of recovery, including memory loss, hearing loss, fatigue, all sorts of things. And in pregnancy, the symptoms are similar to general population, and as I mentioned, like other hemorrhagic fevers, it's often mistaken for other illnesses. And in pregnancy, there is a higher mortality. And the unique thing about this disease is, if in early pregnancy the mother catches, the miscarriage rate is quite high because of placental dysfunction. But if the baby survives, they seem to do okay. But in latent pregnancy, there's reports of vertical transmission. And the diagnosis you can either do by antigen detection, serology, PCR, or viral cultures. So in newborns, again, unless you suspect it, you won't notice it because they present exactly like a very sick baby with DIC. And if a baby is vertically affected by it, there's a high mortality rate. And most of the deaths have been described from Congo, where they found it. So if we have a mother who comes with this infection to our labor ward, we just need to be prepared for a baby being infected and think about it. So the main thing is, how do we manage these babies? They might be asymptomatic. So there are not that many pregnant mothers who have been dealt with, who have had babies, live babies with CCHF. But because of its highly infectious nature, I tried to look at what recommendations. Even WHO doesn't touch upon how you manage newborns, because they're not like a big group which they're bothered about. But reading up the literature, my recommendation would be there should be strict isolation for the mother, because it can be even postnatally transferred from mother's body fluids, even if the baby is protected in utero. And probably avoid breastfeeding. There's no research to say that it is not transmitted in breast milk, but we have to consider it a highly transmissible disease. And observe closely for 14 days. So if by 14 days if the baby hasn't developed an infection or signs of it, it's highly unlikely the baby will develop it. mostly symptomatic and supportive. The only viral drug which has been shown to be of some effect in adults and older children is ribavirin. There's not any reports of use of this in neonates for this particular illness, but you can see lots of literature on the use of ribavirin in RSV. So there is experience with this use of this drug. Of course, if you're going to do this, contact your friendly infectious disease specialist at your hospital or your neighboring one. The other one probably all of us have heard about and probably now forgotten is Zika virus. So when I first came to the UAE, there was an alert saying that Zika virus is spreading, and we were all wondering, when are we going to see it? Touchwood, we haven't seen it here. So it's again another flavivirus, which was a zoonosis initially seen in rhesus monkeys, but the first reported human case was in 1950. And it is again transmitted by the Aedes mosquitoes, and sexual transmission has been reported as well. We think it might not come here, but it is around in the countries close to by here. And one of the places where there's a lot of it is the Maldives, where a lot of tourists go from here and come back. So there is potential that it might be imported back to the UAE, and it can spread because when they looked at viral vectors in the UAE, the Aedes mosquitoes are present in water bodies within the UAE. So it has the potential, and in the wider GCC as well. So in 2015 it was a year after I came here when WHO again declared this as a public health emergency of international concern because of the rapid spread of this in South America, especially Brazil. So far, it's been reported in 89 countries around the world, and there is travel-related spread happening. Since 2017, it's declined back again, so it has been de-escalated as a public health emergency, but we need to maintain vigilance. This is just a map showing where it has been present. So the dark blues are the places where it has been found. The light blues, which are region, GCC and the wider MENA included, are areas where the vector exists. So we need to watch out for this if we see unexpected findings in newborn infants. So what are the clinical features? In adults, it's usually a mild illness. Okay, so incubation is 3 to 14 days. It can have a general rash, some of them present with Guillain-Barré syndrome. And in babies, they're present with microcephaly. And then that led to the recognition of what's called the congenital Zika syndrome. So they have microcephaly, hearing loss, and damage to the brain. Basically, it's because it attacks the neuroprogenitor cells if contracted early in pregnancy. How can we manage this? There's no treatment. Once a baby's got it, he's got it, and these findings are there. Prevention better than cure. So prevent mosquito bites. And the evaluation, it's on history, clinical examination, eye examination, audiology assessment, and you can detect it using PCR. And unfortunately, there's no specific treatment for it. Quickly touch upon the last two diseases, malaria. Again, not commonly seen here, but just last month we saw a mother with malaria in our hospital, and everybody's wondering, how do we manage this infant? So just to jog our memories, malaria is caused by 5 different species, falciparum from Africa mostly, vivax from the Indian subcontinent. Falciparum is the one which causes most severe disease and more maternal morbidity and mortality, but vivax is the one which leads to chronic carrier state. And it is transmitted by the Anopheles mosquitoes. If you look at publications as far as 2023, it will say we don't have the vectors in the UAE, but that's not true. Anopheles mosquitoes have been found in UAE, especially in Al Ain. So the vector is present. And in the last century, they tried to control it, but it spectacularly failed for various reasons. And it was included as one of the Millennium Development Goals in 2000, and billions have been spent on it, and there's been some success. And GCC as a group of countries has been very successful. It used to be quite common in Saudi, but they spent vast amounts of resources on this, and indigenous spread has more or less been stopped. The last indigenous spread in UAE report was 2007. However, the nature of this country and most of the GCC, with workers coming from all around the world, there's lots of reported imported cases of malaria. So that's why we need to maintain vigilance. So if there's a mother who comes with a febrile illness, with rigors and chills, we need to think, is this malaria? Where did she come from? And think about it. So mothers can become quite sick, and if affected early in pregnancy, it can lead to placental dysfunction and the problems because of that. Though the placenta protects the baby to a larger extent, and babies sometimes are protected by the nature of their red cells. They have more fetal hemoglobin, and so also the maternal IgG might protect them. So implications, suspected. It may not even present at birth because of the protective effects, but the bug might be circulating. But once the maternal immunity wanes and the hemoglobin F is replaced, you might start seeing symptoms. So the clinical symptoms are indistinguishable if you look at the reported literature, and if babies catch it, the mortality is high, and most of these reports have come from India. So what do you do if you suspect it? Test for it, but you have to keep checking it every week, at least for the first month, because they can present after 6 weeks. The treatment is mainly supportive, and you can use anti-malarial drugs. The reason I put it there is because this area has got a high incidence of G6PD deficiency, and a lot of these drugs can cause problems. So you need to keep that in mind and always manage it in conjunction with your ID colleagues. Again, syphilis, I'm not going to go through the history because of lack of time. We tend to think because of the area we live in, the incidence will be pretty low, but lifestyle choices have changed. There's more sexual permissiveness, and around the world it's making a resurgence. And we are seeing it increasingly in our pregnant mothers, both local and non-local, because of various reasons. There are no population-based studies in the UAE to say how common it is. So it has increased over the last few years, and increasingly pregnant women are coming with it. The implications are it's easily treatable. In pregnancy, it can lead to all these complications, and we routinely screen for mothers. This is the algorithm we use in SAHA. But the bottom line is, if you suspect it, look for it, and if you think you cannot follow up the babies closely, treat it, because you might miss the boat to treat them later. So whenever we call our ID specialists, they say, give the baby penicillin, because some of these mothers don't come back for follow-up. Last but not least, vaccine-preventable diseases making a resurgence. Pertussis has increased dramatically in the last few years. Up till 2023, this is the UAE WHO data, we had 91 cases, but the last year's data, it's not been released yet, but speaking to ID colleagues, there's been a massive increase in pertussis, especially in the UAE, with neonatal deaths and babies ending up on ECMO. So we need to be aware of it. The main thing is prevention and the promotion of Tdap vaccine in mothers. The uptake is quite low. There's a big plan from DOH to have a public health push to promote this. So to wrap up, emerging and re-emerging infectious diseases pose a risk to mothers and newborns around the world and of course in our region. And in our region, we are unique in the sense because of the geography, the population dynamics, and rapid urbanization, and we have to remain extremely vigilant for these diseases. Thankfully, we have strong public health bodies which are doing that at the moment, and prompt recognition and isolation and management is vital for containment. Those are some of my references. Thank you.
Thank you, Dr. Hafiz, for keeping up with time and summarizing most common infectious disease in neonate with great concern. Now I'd like to take this opportunity to call upon Dr. Junaid Khan, who is the conference chair for today, and also is a consultant neonatologist at Sheikh Shakbout Medical City, and also the program director of neonatal program. And today he's going to talk a very important topic of rationalizing RSV in infants. Please welcome Dr. Junaid.
Okay, so thank you very much. Thank you once again. We are continue the infectious disease session, and again, I'm going to talk about the virus. So this is my disclosure because many people think that it is a company-oriented thing. It is not. All slides are my slides based on the scientific evidence, and my reference is the CDC and the Advisory Committee on Immunization Prophylaxis to CDC, American Academy of Pediatrics, and National Foundation of ID. So this is nothing to do with the company. Actually, we are trying for this season that if we can move from 5 doses to 1 doses, so we will go from that. So we will very quickly go through the burden of RSV and what other options we are having, and then how we can implement that. On top of that, there is a framework by American Academy of Pediatrics, and when this medicine approved there, they pose 5 questions. The public health problem, which is yes, benefit and harms, values, acceptability, feasibility, resource use, and equity. So all these, by the end of the talk, I try to answer those questions, and then we will see if it is feasible or not. Very quickly, the background of RSV is a respiratory syncytial virus because it affects the epithelium of the respiratory tract. The first is in 1840s, but the first isolation from the chimpanzee in 1956 around. And the third one step is the Robert Hancock in 1963 characterized the virus as a result in RSV. So it's a really old virus we have, and we are dealing with that. Now, this is the, looks like the coronavirus, and I will show you some impact of that, but it is the paramyxovirus. RSV is a single-stranded, have a G protein and F protein. And these two proteins are the main which cause the pathogenesis. So the F and G proteins are the crucial for the infectivity and the pathogenesis of the viruses. Now, how it is affect? It is affect from the 0 up to the elderly age. So the newborn can have the respiratory tract infection, either the upper or the lower, then in the childhood, then in the adolescent, and then elderly. So this virus can affect any of those age group. The global burden, as by American Academy of Pediatrics, is, the World Health Organization said that 63% accounts for RSV as compared to the other viruses, as you can see in the chart. And on top of that, this is a 33.1 million RSV related acute lower tract respiratory tract infection. So really, it is a lot of infection because of this one single virus. So the burden of the disease with the data provided from the USA CDC is increasing, is about 58,000 to 80,000 hospitalization, is less than 5 year old, 2.1 million outpatient visit. I will give you what happening in UAE. I will give you some data from the UAE. Now, if you see the meta-analysis of 55 randomized controlled trial, risk for every 1,000 patient less than a year is the main targeted babies or patients all over the world because of they are developing their immune system. So the RSV is a leading cause of LRTIs, lower respiratory tract infection among infants worldwide. The data, the latest data suggests about 46% in the United States, but look at the France, it's about 81%. And GCC countries, 22 to 26%, but I will give you the UAE data in a couple of minutes. China is 27 and Japan is 28. As I said before, that RSV remained the problem for that many years, and it is not decreasing, it is actually increasing. And globally, they are spending a lot of money, 33.1 million new cases per year and 3.2 million hospitalization, which costs a lot of cost on the healthcare. So the limited treatment option and prevention is the key, and we will talk about the prophylaxis. So the hospitalization, if you see all over the world, is 72% in USA, United Kingdom is 83%, and so on and so forth. Saudi Arabia, which is near us, is 75.7%. Now, this is the very important, if you take the prophylaxis, what we are doing now, we are catering only 1 to 4% of the, as I said there, 4% from our infant, if you have 100% compliance. So let's say you are giving prophylaxis according to your guidelines to 100% of the babies who require that prophylaxis, you only cover the 4% from it. So what is in the UAE happening right now? The overall incidence around 30%. It is just published in 2023 Journal of Natural Sciences. The head of infectious disease in Department of Health, Dr. Nawal Kabi's data. And they give the infectivity according to the season, that which month is the highest. As you can see, in October, November is the highest, then December, January, and February. Not only that, if you look in this publication also from UAE and from data from 2014 to 2023, the season variability is increasing. As you can see, the lowest graph, which is 2014, the blue line, is a flat line. There is no variability. But by the passage of time, it is increasing, and in 2022, as you can see, is purely the season infection is a very high season variability. Sorry. So not only in the UAE, but also in all over the world, that less than age of 5, the post-COVID pandemic, it is increasing. So 2000 to 2004, 2016 to 2020 is yellow, but look at this after the COVID. 2021 is very high, and it is statistically significant, as you can see here. Now, the irony of fate, that if you remove and if you separate the babies, which is less than a year, there is the effect of COVID is not there, because 2016, 2020 is already increased. So you get my point that the COVID overall effect, if you take the baby of 5 years, less than 5 years, but if you separate that a small group, the COVID effect is not that much there. Now, this is no-brainer. This is from the Picnic, very fancy name, Pediatric Investigators Collaborative Network on Infectious Disease in Canada, and they find it out that higher the complication, the higher the fatality rate in it. Not only those specific diseases with that group, but other than that is neuromuscular disorder, trisomy, cystic fibrosis, immune deficiency, babies or the children who have a BMT, bone marrow transplantation, or the solid organ transplantation, they all having this problem. Now, RSV infection in the preterm or the late preterm babies, so this is the higher risk, and if the baby is less than 35 weeks, if the baby born and have the BPD, a bronchopulmonary dysplasia, and the baby has a critical congenital heart disease, the chances, the burden of the disease is very high, and the chances of having hospitalization ICU is very high. So come back to the seasonality, that we know about the virus, we know about the complications, we know about its effect. So these are the different areas of the world, the northern temperate regions, northern tropical, equatorial, southern tropical, and southern temperate. It is different in different areas. So if you divide the world by the equator, the northern hemisphere and the southern hemisphere, you can find it out, the variation in the seasonality. So this is the weeks from 27 weeks to 25 weeks of June, and it is varies in the different years. So for example, if you take the red line, which is 2022-23, it start increasing 35 weeks of that year, and then goes down in 9, which is approximately the same what we are having the season here. So we decided initially when we start the RSV prophylaxis, I was involved in that committee, that October 1st and the March 31st is our season. The management of the RSV, we don't have that much management. As Hafiz said, most of the viruses we don't have the management, only the supportive. The prevention is the main thing, the infection control is the main thing, prevention of the severe LRTI, and then is the immune prophylaxis. So I will talk about now the immune prophylaxis. There are three approaches may provide the protections. One is the traditional MFs, which is pelvizumab. It is approved in 1998. Then maternal vaccine, which is just approved in August 2023, and the long-acting apps, which is just approved in July 2023. So the mechanism of action is the same, that it affects the F and the G protein of the virus, and it affects the site different than other MABs, which is pelvizumab, which make it as a long-acting. So not to go into the detail, as you can see here, the yellow circle is the mode of action there, which is the control the other pre-F and post-F areas, and it will be more effective and long-acting antibodies as compared to the other. Now we will go to the evidence, that what is the evidence and this thing. There are many studies, Medley study, Harmony studies, and all those give the thing. So I don't want to go in the details. You can find it out in the literature. But I will give you some details about the what are the results. So the efficacy estimates from the clinical trials is about 79% with a lower respiratory tract infection, with hospitalization about 80.6%, and so on and so forth. So it is really, efficacy is very high of this one-dose immunoglobulin. From the other clinical trials, as you can see, the pink line, the efficacy increased to 5-fold higher than the other competitors, and then it's 7-fold higher at the 36th month of the life. Then the next question is the safety result. So safety result is very comparable to placebo. 968 babies give the nirsevimab, and the placebo is 479. And as you can see that all these adverse reaction is almost the same in both groups. So if you summarize the great grading of evidence for nirsevimab for the after the first season, the medically attended RSV LRTI, that not the hospitalization, is high, that it is effective and it will help the baby. With the hospitalization is also, as you can see on your right-hand side corner, this is high, the evidence type. Then if you give it the ICU admission is moderate. The associated with death or mortality, because we have only one season with this new drug, so the data is not available, and the others are serious or adverse effect is very, very less or likely not be possible, and this is also the moderate evidence. There are more evidences, I can give it to you, but these are the main summary of the evidence. The last one published in the New England Journal of Medicine in 2023, and they said this adverse effect is only 1.3% as compared to the placebo, which is 1.5%. So the efficacy against medically attended for RSV LRTI is 76%, efficacy against very severe is 78.5%, and hospitalization reduction by 78%. So the benefits and harm summary, it is there, and it is moderate to large evidence, and it outweighs. This is the poster by the mortality morbidity weekly report, and they said that 90% effective. I don't know if it is company based or not, but this is I got the poster from MMWR. Acceptability. So it's very easy. It's again a no-brainer, not a rocket science. 5 doses versus one dose. If it is my baby, I prefer one dose. So they did the survey in USA with the pediatric providers. 85% agreed, parents agreed, and there's a high acceptability to use this. So the American Academy of Pediatric and National Foundation for Infectious Disease Roundtable have stated that it is safe and effective for RSV prevention. Cost effectiveness. I am pro financial stewardship. as I am member of many committees for antibiotic stewardship. So financial stewardship is yes, but I am not, the financial advisor or something, but it is very easy to calculate that it is increase the quality adjusted life year, it decrease the doses and the cost. So the cost, if you, this is the graph from the ICER, International Commerce and Economic Research Center, and they found it out that if the baby has lower respiratory tract or upper respiratory tract, you will be saving quite a lot of money on that. So in conclusion is that the nirsevimab for infant may be cost effective. Now, the one dose in USA before tariff is $495. I don't know how the tariff will affect. And how much is here, if you convert in dirhams, it's around 1,600, 1,700 dirhams. If we get the same dose here, as compared to one dose of palivizumab, is about 4,000 dirhams. So 20,000 dirham versus 1,600 dirhams, or at the most 2,000 dirhams. We don't know what is going to be the cost here, but I'm just speculating. Now, what are the algorithms? So this is from the American Academy of Pediatrics Red Book. We are designing our own for Abu Dhabi, and it's going to be almost the same. So October through the March is the season. If yes, if the patient is less than 8 months of age, or if the patient is out of season, it's not recommended. So let's say if the patient is less than 8 months of age, then the answer is yes. Then of course you have to see that the mother received the RSV vaccine, which is the new vaccine, and it is also coming to the UAE. So if the mother received the vaccine within the 14 days the baby delivered, then of course it is you have to give the nirsevimab. If not, then it is not recommended that 2 vaccines you should give. If mother receives the vaccine, that's good enough. So what is the patient current weight? If it's less than 5 kilogram, give the 50 milligram, and if it is more than 5 kilogram, give the 1 dose of 100 milligram. What happened to the smaller babies? So the right-hand side is the same, which I showed you, but let's say on the left-hand side is the baby is less than 6 months of age, then again you have to give the dose of nirsevimab. If not less than 6 months of age, if the patient is less than 8 months of age, then again we have to go to the other scenario. So these are the journal guidelines, and we are making our own guidelines according to the basis of that. Now, what are the other consideration and acuity? So if the nirsevimab is given to some patient, you don't have to give the palivizumab. If the baby have a palivizumab less than 5 doses, then you can give 1 dose of nirsevimab, and that's it. Within 30 days of palivizumab, you can give the nirsevimab dose. So this is the main, what you call difference between the two medicines. Now, if the baby has a high risk like chronic lung disease, congenital critical heart disease, cystic fibrosis, then as I said, that we recommend that we should give those babies, even if the mother is prophylactic. So value proposition, the side-by-side comparison, the prophylaxis for all infant, nirsevimab is a target profile for all the infant. Palivizumab is only less than 2% of the birth cohort because we have this guidelines, less than 29 week or other risk factors. Efficacy is more than 70% as we treatment is only 1, and market access as we already compare it. So these are the doses. These are recommended by the ACIP and the AAP recommendation in the new Red Book, which is 2024 to 2027, and these are the same which I just mentioned. So to make it easy, if a baby born before the season. So when the season starts, he should receive the dose. If the baby born during the season, then of course he can receive a dose at the same time before discharge of the NICU or postnatal. Administration is easy, is the same, but people are, when the new things come, so American Academy of Pediatrics very specifically that what is the size of the needle, what is the injection site if the baby is less than 28 days, if the baby is 1 year, and toddlers. Sorry. So this is just to make it, but I think all of our nurses, all of our staff are very experienced and they can deal with that. Adverse reaction, so far what they notice is the rashes, injection site, reporting of administered alone, report to the MedWatch, or administered simultaneously with any vaccine. So in USA, they recommend that you should reporting these adverse effect. But so far, the only adverse effect is the rash. Now, if the mothers get the vaccine, as I said, and if the baby has some chronic chronic disease, then it is recommended to give the vaccine. If the baby do not have any other chronic or any other risk factor, then there is no need to give the dose of nirsevimab. So this is the medicine which is approved by the FDA in 2023 and CDC also in August 2023. This is the schedule from the USA, immunization schedule published in January 2025. And as you can see, the first one is the RSV. So now what's happening around the world? So these are the pink, light pink color and the dark pink. So the dark pink colors are already started the program. And the light pink color in this season, 24-25, they are already started. So which is Saudi Arabia, Kuwait, and all those things. This is the guidelines. This is the protocol by the Saudi Arabia. It's called Saudi Initiative of Bronchiolitis Diagnosis, Management, and Prevention. And they have their own guidelines for that. And we are, follow the same path, and we are making our own guidelines. Irish already has one season, and they published their data, the efficacy. So 41 cases of RSV were noted compared to 656 cases, which is decrease in 94%. This is only the Ireland. Ireland is not a big country, but still, this data tells you a lot of things. 24 babies were hospitalized compared to 413, so decrease of 94%. And similarly, the 5 babies needed treatment in ICU, which is decreased to 92%, and it is 64%, 64 babies as compared to the 5 babies. So the summary is recommended population is universal, efficacy is 70 to 80%, and treatment burden is one single injection for that. So I showed you this diagram. So that framework set up by the American Academy of Pediatrics. So what they answered these questions they asked before the first season. So after the first season, the public health problem, he said, yes, it is a big public health problem. Of course, we know benefits and harm. So the moderate to large evidence according to that framework is minimal to small, harm, which is yes, and values. Yes, probably, because it is very comparable. Acceptability is also the answer yes. Feasibility is yes. Resource use, also the answer yes. And equity is also probability increased. So this is the report that evidence to recommendation framework summary, work group interpretation, children at the increased risk of severe disease entering into the second RSV season, so they recommend the intervention. These are some FAQs by the AAP.org. If you go to that site, you will find this. So they ask some questions and then they answer it. But we have a question answer session. If you have any questions, just ask, and then I'm able to answer all these questions. So my conclusion on that, okay, is only 2 minutes, I'm just finishing, that among preterm infants or about high-risk infants, there's a substantial burden. On top of that is a substantial burden with the full-term baby, healthy babies also. Is the severe and cost is very high of RSV infection with the admissions, ICU admissions, and a whole bunch of that. So we have to have something to get a very good or robust prophylaxis of this disease. So my conclusion is there is no vaccine and no effective treatment for RSV infection. Supportive treatment is the mainstay. Prophylaxis against RSV includes infection control in hospital and community, breastfeeding and breastfeeding and breastfeeding, and prophylaxis not the targeted group, but to all infants. With that, I will thank you very much. Thanks a lot.
Thank you, Dr. Junaid, for a very informative talk on the most hot topic emerging today. And now I'd like to take this opportunity to welcome Professor Hakam Yassin, who is a consultant neonatologist and head of pediatric and neonatology department at University Hospital Sharjah, and also the medical director and member of board of trustee University Hospital Sharjah as well. And he's an assistant professor of pediatrics at University of Sharjah. Please welcome Dr. Hakam Yassin. He is going to talk on a very important talk on role of oral antibiotic. What are the safety and importance of it, and update on it. Thank you.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you, Dr. Manzoor, for the introduction. Thank you, Dr. Ayman and Dr. Junaid, and all the members in the scientific and organizing committee to invite me for the 14th time to this excellent conference. So let's start with this. We speak today about unusual introduction of our administration of antibiotics through the mouth for neonates. So what's the evidence? So you will see that most of the literature, it's coming from studies coming from India, Pakistan, Africa, of course supported by WHO researches. And of course, recently I would present also some Western publication about the same subject. And recently when I saw, I was in France, we were using in late 80s and early 90s oral antibiotics for neonate as switching treatment. And he told me that yes, they continue in France to give this type of antibiotics. Let us start to storm our brain by a clinical scenario. A term neonate presented with tachypnea at 2 hours of age. His mother had pre-labor rupture of membrane for 28 hours, which is a risk of infection. Mother vagina swab showed GBS positive. The baby was admitted into the special nursery care. The infant was screened for infection and, as usual, started in the empirical treatment, penicillin and gentamicin. The initial CRP was moderately high, 56, and lumbar puncture was normal. At 48 hours, the baby appeared well, was feeding normally in room air. His blood culture was negative, and CRP went down to 19 milligram per liter. Parents requested to go home. So the question here, is it safe in this case to switch from IV antibiotics to oral amoxicillin for home discharge? So what is the present practice in general according to the larger bodies like AAP and NICE guidelines? The current practice is to administer antibiotics IV for entire period of around 7 days. However, IV therapy has disadvantages, including the need for hospitalization, IV insertion and reinsertion with possible separation of the mother. There is emerging evidence to explore the effectiveness and safety of switching antibiotics from IV to oral therapy in neonates with asymptomatic early onset. So what is the aim of this presentation? The background, switching from IV to oral antibiotics therapy among neonates is not yet practiced in high-income settings due to uncertainties about exposure and safety. On this presentation, we want to assess the efficacy and safety of early intravenous to oral antibiotic switch therapy compared with full course of IV antibiotics among neonates with probable bacterial infection. So what about the absorption? Let us start with the most common used ampicillin and amoxicillin. So absorption of oral ampicillin and amoxicillin was evaluated in several studies in newborn gestational age between 28 to 40, so extreme preterm baby also, and postnatal age is 0 to 6 days. Following IM injection, the Tmax time to reach the maximum concentration Cmax was 30 minutes, whereas this was on average of 4 hours. So by IV. So sorry, half an hour, 30 minutes when it's giving parenteral and 4 hours when it's giving orally. Compared with adult, Cmax was higher and was reached later in unit. And because of that, they mentioned that you will see in the presentation that giving the oral antibiotics, perhaps it would be safe as a switch off, not as initial treatment. So another randomized study in neonates suspected of bacterial sepsis compared oral with IV amoxicillin. It was found comparable concentration. This is another study will reach 2 hours after oral administration. Another study has been performed among 44 neonates receiving IV gentamicin with oral amoxicillin, sampling 2 to 3 hours and 6 to 8 hours after oral administration showed concentration exceeding the susceptibility breakpoint of amoxicillin against strep pneumonia. So in preterm and term newborn was probable bacterial infection treated with oral amoxicillin. Study showed that no relapse, also there's a risk that perhaps there will be a reinfection. So in this study, they found that, or they showed that no relapse was reported after oral treatment of 40 milligram per kilo per dose. They are giving 80 milligram per kilo per day. Moreover, no side effects occurred and all measured serum concentration were reported to be above the MIC of targeted pathogens. An uncontrolled IV to oral switch trial was performed in 222 term neonate with probable of proven GBS sepsis. Subject switched to oral amoxicillin as 100 milligram per kilo per day, divided every 6 hours. All infants had to be asymptomatic and orally fed at the moment of switch. Serum level were all above the MIC for GBS. Moreover, therapy was well tolerated without any side effects or reinfections and reduction of 5 days in hospital admission. They are starting the treatment at 48 to 72 hours and then they discharge baby home. So they decrease the length of his stay and the separation of his mother. Now, this is a multi-center study in Denmark, switching study from IV to oral amoxicillin. The method here, 8 centers contributed to the prospective cohort study in Denmark, in which around 500 term neonate with probable of proven early onset infection had antibiotic switch from IV penicillin and gentamicin to oral amoxicillin after 48 hours of complete 7 to 14 days. All infants successfully tolerated oral medication and were able to complete the course. There were no readmissions reported, and 11 neonates with positive blood culture. So out of these around 500 neonates, there were 11 neonates with positive culture, and they continue oral antibiotics successfully, switching oral medication. The conclusion of the Denmark study is a multi-center study. In this prospective cohort study, 90% of eligible neonates underwent oral switch therapy. There was no readmission due to infection among the 478 neonates with probable infection. The median hospitalization was reduced from 7 days to 3 days. The population-based use of antibiotics did not increase after switch therapy was implemented. So it did not encourage people to give more antibiotic because we will give oral. So it was the same. So now, what about the amoxiclav, like augmentin or whatever? So a retrospective study evaluated the clinical course and treatment of 172 newborn with UTI. In total, 119 patients switched to oral. You know, in pediatric population, the augmentin or the amoxiclav is the treatment of choice as empirical treatment for UTI. So they use the same for neonates. None of the orally treated newborns experienced a relapse in the 6 months after treatment. In another study, oral amoxiclav acid, the dose is 80 milligram per kilo per day, in 2 doses. It was administered successfully to neonate at risk of infection. There was no reinfection or treatment failure in the first month after treatment completion. This is an Indian study about the amoxiclav. The objective to compare oral amoxiclav acid with injectable ampicillin and amikacin for the management of asymptomatic neonate born to mothers with risk factors for infection. The method in this randomized control trial was conducted in neonate, and they are all of them more or equal 34 weeks, asymptomatic infant with maternal risk factors for infection. Newborn were randomized to receive either oral amoxiclav or injectable ampicillin and amikacin within 1 to 3 hours after birth. The result, 126 newborn were randomized to receive either oral coamoxiclav 63 or injectable standard treatment. Treatment was administered and tolerated successfully without a report of reinfection or a treatment failure. Their conclusion that oral coamoxiclav is as effective as injectable ampicillin and amikacin for management of asymptomatic neonate born to mothers with risk factors for infection. No significant adverse drug reaction between groups. This is again amoxicillin, clavulanic acid. This is the Netherlands study. A multi-center randomized 17 hospitals. It's a big study in Netherlands, open label, non-inferiority trial. Amoxicillin, clavulanic acid was conducted. The RAIN randomized control non-inferiority study included late and early onset infection in neonate more than 35 weeks gestation. The study included neonate who had blood culture negative with raised inflammatory marker, CRP, and like the same scenario that we mentioned. Also have maternal risk factor and other clinical parameter. In this study, neonates were randomized to two groups: oral amoxiclav after 48 hours of IV. They prefer to give IV, as we mentioned that it's the it take 4 hours compared with the IV antibiotics to reach the maximum in the blood. So after 48 hours to 72 hours, giving oral. The other group, it is the standard group, they continue the 7 days penicillin plus gentamicin. Their primary outcome was bacterial reinfection rate within 28 days. The conclusion of the study, the oral antibiotics arm showed no inferiority with excellent tolerance to oral antibiotics and shorter hospitalization compared with the IV group. Now about fluoxacillin, nafcillin, to see the level. So level of fluoxacillin and nafcillin have been reported following single dose administration and combined with other antibiotics to a newborn. So both drugs appear to be absorbed faster than other penicillin, so it is good absorption. Cefilaxine, first generation, a study from Pakistan described the outcome of oral management in neonates with clinical omphalitis. And omphalitis without sepsis were treated with cefilaxine suspension, 50 milligram per kilo per day, with a success rate of 99.5%. Conclusion study was showing that outpatient treatment of clinically well neonates with omphalitis using oral therapy is effective. Linezolid, also, you know that we are using it for staphylococcus. In a retrospective study, 5 preterm infants treated for late onset sepsis who experienced renal failure switched from IV vancomycin to oral linezolid. The Cmax for all patients but one was above the measured MIC for the causative pathogen. Now, we'll go to the low middle income country settings. There is a challenge in these countries that there is no bed available. And we will compare mortality before and after using the oral antibiotics as you will show that giving oral antibiotics will decrease the mortality in this group. So in a Nepalese study for neonate sepsis, oral co-termoxazole was administered in combination with IM gentamicin to 67 newborn with a possible bacterial infection. The authors reported 100% completion rate of oral therapy without any treatment failure. An Ethiopian trial evaluated all these studies. It is under the control of WHO standard. It's not a small study, it's big studies and well-controlled studies. Trial the implementation of IM gentamicin and oral amoxicillin versus standard treatment. Result seems promising with a decline in mortality from almost 18 deaths per 1,000 to baseline to 9 per 1,000 in the intervention group. Mortality rate were not significantly lower. And between the standard and the oral, no difference. But when they start the oral, then it was oral or not, of course. Then they decrease the mortality. There are other 3 randomized controlled trials with a total of 8,834 subjects compared regimen, including oral amoxicillin with 7 days plus 2 days IM genta versus standard IM regimen, penicillin and gentamicin for 7 days in a newborn at risk of severe infection. They are symptomatic. The first trial was in Bangladesh, including an oral switch regimen among 2,490 children. The second and third in Africa, in Congo, Kenya, and Nigeria, including 3,564 infants aged from 0 to 2 months. The primary outcome was treatment failure within 8 days, defined as death, clinical deterioration, hospital admission, or treatment-related serious adverse event. The mortality within 2 weeks after enrollment was comparable in both groups. So the mortality within 2 weeks after enrollment was comparable in both groups, and other parameter with no difference also. So the analysis and comment in the previous studies, in general, adequate serum level according to the MIC of relevant pathogen can be achieved after oral antibiotics administration in neonate, according to this study, and Cmax is reached later after oral administration. In one study, they mentioned later around 4 hours, the other say 2 hours to reach the Cmax between the IV and the oral. Thus, initial therapy should consist of IV. So if we will give oral antibiotics, all the recommendations, they mentioned that give the first doses orally. The first, I would say, 48 hours, 72 hours, IV, and then you can work as switch therapy, not initial therapy if possible. Then be switched to oral therapy once the neonate is clinically well. The efficacy study showed good tolerance of oral therapy compared with IV therapy without reporting an increase in side effects. Moreover, in 2 studies, oral administration led to a shorter stay in hospital and more exclusively breastfed infant. In low-income countries, mortality rate have decreased through the introduction of home-based therapy when referral is not possible, and simplified antibiotics regimen with an oral switch have shown efficacy similar to that standard IM. In most studies, clinical efficacy, bacterial reinfection, or treatment failure is used as a primary outcome. Given the effect that bacterial reinfection rate is low, a much larger study sample is needed to show non-inferiority or efficacy. Non-inferiority, needs the margin of 20% instead of 5%. In low-income countries, simplified regimen included oral antibiotics are already recommended by WHO. So this, it is not, WHO, they recommend in low-income country to give oral antibiotics because they found that it's effective. Given these limitations, the currently published study cannot be used as conclusive evidence, so to safely change the current guidelines on management of neonatal bacterial infection. However, the findings do give the impression that such study may be undertaken safely. So recommendation here, intravenous to oral antibiotics therapy switch at 48 hours to 72 hours from commencement of antibiotics is probably safe among term neonates with early onset sepsis who are clinically well, feeding orally in a special situation when difficult intravenous also insertion or there is no bed availability. So hospital that they have units, busy units, and they have admission, and so they can follow this. Safety post-discharge protocol is very important. So when you discharge the baby, should follow the baby in the clinic. For example, what we are in the university hospital, we are following that. We are giving oral switch antibiotic, and we are seeing the baby after 2 days. So change antimicrobial prescribed practice, then you need to get microbiome and the possible development of antimicrobial resistance. So we'll go to the conclusion. Oral antibiotics administered to neonate are adequately absorbed and result in adequate serum level judged by MIC of relevant pathogen over time. Efficacy studies are promising, but the strong evidence is lacking, most importantly because in many cases clinical efficacy and safety are not properly addressed. Early oral antibiotic switch therapy in neonate could be beneficial for both families, breastfeeding and healthcare symptoms, and of course, insurance companies, they will be happy also. IV to oral antibiotic switch to complete the course of therapy may be acceptable in culture negative term neonate with early onset probable bacterial infection who are clinically improving and tolerating oral feed. There must be outpatient clinic monitor, follow-up, few discharge and oral after 2 days, better to see the baby. Studies included only term neonate with asymptomatic early onset probable bacteria. We don't, of course, discharge symptomatic at home in oral, so it should be asymptomatic. So the result cannot be extrapolated to preterm neonate, symptomatic, or neonate with confirmed sepsis culture proven. Although, as you saw, the Denmark, they have part of them, they have positive culture and they continue oral successfully. There is a need of additional well-designed trial in different settings. Thank you very much.
Thank you, Professor Hakam, for a very informative talk on a promising trend of role of oral antibiotic in asymptomatic neonates. Now, to continue further, I would like to invite all the distinguished speakers on the dais for Q&A session. Dr. Hafiz. Yeah.
I have one question for you.
Assalamu alaikum. Thank you very much for the presentations. My question to Dr. Junaid.
Yes.
One is comment on the comment, and the other one is the question about the validity of the presentations. Okay, the comment that we cannot question the CDC or the American Academy of Pediatrics. I think we can. I think no one is immune from questioning. I think whether CDC or the American Academy of Pediatrics, based on the research and the results of the research, we can question them. We can question their tools that they use to reach the conclusions. I think we can.
Yes.
Okay.
Of course.
The other points is that I can see the Nizolimab saying that there is 73 efficacy, and I think if we look at the result from the literature that you use, it reduces from like the admission from 1.5% to 0.3%. But when it is like magnified by the times, we can say reduce 300 times or 400 times. But the figure is really, really small, from 1.5% to 0.3%. And the other one is that the literature that they used, the study that they used, it was not blinded. The company that used the study, they didn't blind the patients, they didn't blind the doctors.
Yeah.
So the decision of admitting the patients because of RSV, it's really because it's not blinded. So how can we remove the bias on these kind of studies? And if we look at the studies are supported by the AstraZeneca and the manufacturer.
Sure.
So it is very...
Can I just answer
Okay,
that?
yes.
Yeah. So the first thing is first. First of all, I didn't use any study from the company, okay? If you see it's a very new drug, it's only 1.5 years ago it's approved. So the first season results I showed you in the Irish. It is by 90% reduce in this, 94% reduce in that, 94% reduce in ICU admission. So it is much more effective. Then if you see the effect of 5 doses as compared to 1 dose, this is the major task. And by the way, the nirsevimab molecule is made by AstraZeneca. In other part of the world, is the AstraZeneca is distributing it. Here only is the Sanofi took it. So it's the same company who making palbociclib, they make the nirsevimab. So this is just to correct for you that there are two other companies. No, this is the same company. Okay, here the distribution by the Sanofi. So this is one thing. Second thing is that think about that if you have to give 5 injections as compared to 1 injection, which one you want to do? And nowadays everything is financial stewardship. So it is very much effective. So I told you in USA is a $495 for 1 dose as compared to $7,000 total for 5 doses. I mean, it's
I agree. That's definitely it's better than the previous cost. It came down to like 3,000 for the prevention, or if we can say prevention, because it doesn't prevent. It prevents the admission that it is subjective still. Anyway, it's still we are advocate for the parents and how much they spend to whether reduces the admission or prevent this disease. We have to be advocate. So we can't question the tools.
of course, we have questioned the cool. That's why many other studies are coming up, and that's is happening.
And the other thing is that they use the Kali, and the Kali is all subjective to look at the effectiveness. And many European countries since 2012, 2013, they abolished the Kali because it is subjective. Anyone can manipulate that.
But they are again doing the same. Like in, I didn't show you the France. France is doing it for long. Spain is already, doing for since 2023. So there are evidence which is high grade evidence. I give you the framework of AAP. They evaluate all the evidences, okay? And then they come to that recommendations which I showed you. It's not that they are not reducing the bias. They are separate entity from the American Academy of Pediatrics. They make a framework to evaluate the evidence for that medicine. So that's how we evaluate the biases.
I think
Can
we'll
I just
take the
make a
next
comment
question.
on that? Because I looked at the same thing a few months ago. The problem which the nirsevimab had, all the RCTs were done during COVID. So RSV incidence was very low as such in the population. That's why they couldn't show that big a difference as during the palbociclib era. But there are a lot of post-marketing studies which are not, as you rightly said, the same as an RCT evidence, which shows. So it's weighing up the risk-benefit ratio. But I think the world is moving towards it.
Okay, I mean,
Thank you.
No, but we can question that.
Absolutely,
We can
absolutely,
question the evidence.
absolutely.
We can question the
No
tools.
doubt about it.
Okay.
Thank you very much. Next question, please.
Thanks so much. I'm Dr. Omar Abu Saada, consultant neonatologist at Hospital. My question to Dr. Hakam Yassin. As you know, we have a lot of non-infectious causes that for which we admitted babies to little ICU who are symptomatic, like TTN, traumatic delivery, etc. And there are many causes that lead to increase in CRP than infection, bacterial infection. So my question, what about the result of the oral antibiotics versus the IV antibiotics that are inferior? That because these babies don't have infection to start with, there's no bacterial infection.
Yes, I agree with you. We are sometimes overusing the antibiotic. But you see, if you return back to the same scenario, mother, she has 28 hours of rupture of membrane, GBS mother, and he has tachypnea in the beginning. And the CRP is in the 50s. So we should, of course, be careful about this baby and to treat. Now, starting the treatment sometime, we are continuing the treatment because the CRP did not come to the normal. So this is an suggested treatment to, instead of stop antibiotic unsafely, to continue with oral antibiotics. And as we mentioned, the study in several studies, they mentioned that they decreased the stay in the hospital and decreased the separation with mothers.
Thank you.
Even though, if you see that in some studies, they were moderate to severe infection in Africa, and it was successful. I'm not, of course, discussing here the indication of antibiotic, which I agree 100%. Sometimes we are over-treating with tachypnea, TTN, or whatever. Yes, I agree. This is all of us, we are doing it. But to be safe, mainly for our babies, we are starting antibiotic.
Do you have policy at the Sharjah Hospital for this?
Well, there is no written policy, as perhaps we should do it now, this from recent study 22, 23, 24, and the last one is in Archive of Disease of Childhood 2024, pushing for that. But they mentioned that we cannot generalize. I cannot say to all the colleagues to do it because I am not a body to recommend. But if there is evidence, in some cases, a switch treatment, if not initial, a switch, yes, I'm using since several years, since I would say 9 years, alhamdulillah, no case readmission or reinfection in our records. So, but I cannot generalize. I am only giving the lecture what is speaking now. In Africa, they have. WHO, yes, they have. And they have for the low-income countries.
Okay, thank you.
Thank you. Our colleagues in India, because I know colleagues in India, Professor Lucky, he was with us in the last, and he said, yes, of course, we are using it largely in India. And colleagues in Pakistan, I ask also the colleagues there in good hospital like Aga Khan, they are using also oral antibiotics for these cases.
Assalamu alaikum. My name is Syed Hussain. I'm a pediatric neurologist at Sheikh Shahood Medical City. And my question is regarding vaccination, and particularly what Dr. Junaid talked about. It may be a little bit out of context, but I thought that it would be relevant to ask this question.
Sure.
We have been, parents come with autism spectrum disorder and they still believe that vaccinations are to be blamed for it. There's no evidence for it, and in fact, most pediatricians know it. My question was regarding nirsevimab. It's a passive immunization, and in fact, the comment is that there has been evidence to show that nirsevimab administration actually reduces the symptoms of autism spectrum disorder. Would anybody be able to comment on that, or are you aware of that?
No, because it's so new. As I said, that August 2023 is approved. So nobody look into that as regarding to the autism. But maybe later on, okay, autism is mainly they are talking about with related to MMR as compared to other vaccines. But for this thing, to my knowledge, is no. You, Hafiz, you have?
I haven't come across that data yet.
No, I don't believe there is any relationship of vaccination with autism for sure, but you all know parents are always concerned about it. But nirsevimab, specifically I'm talking about, actually has shown to improve symptoms of autism spectrum disorder, and it is one of the new agents that may actually be approved for ASD.
Oh.
So it's contradictory to what we always learned about vaccination. So I thought it would be something that people actually should know about.
Sure. I think thank you, Arif, very much, because I don't know. When I went through, I strictly on the prophylaxis. But this point, I will take a look. Hafiz?
I haven't seen it before. That's new to me. Interesting data.
Yeah, I mean, I didn't know about it either till I was asked to give a talk on autism spectrum disorder very recently. So I was searching for some new information, and that's how I found it actually.
Okay.
So I thought it would be important to share with you guys and reassure parents that no, ASD is not related to vaccination.
Sure.
In fact, there are some new prophylactic agents that could be beneficial in reducing the symptoms. Thank you very much.
Thank you, Arif. Thank you. Thanks a lot.
Thank you for sharing this very good information for all of us to learn about. Now, if there is no more questions, I would like to sum up this session and invite the colleague to facilitate our speakers for today. After this, we'll have 1 hour break and we'll join back at 1:45 p.m. here for the third session.
A big thank you to our amazing speakers and moderators for the insightful session this morning. We'll proceed with the certification of the speakers. Dr. Hafiz Ibrahim. Dr. Hakim Yasin. Dr. Junaid Khan. And Dr. Junaid will proceed with the certification of Dr. Manzoor Ahmed. Lined up for the afternoon. Let's now take a break and regroup at 1:45 p.m. Delegates may proceed to Sahar Restaurant on level P2. Enjoy your lunch break.